patients are actually innovating, and they're innovating faster than pharma, innovating faster than research bodies and academic institutions. Does that surprise you? No. So we had Dana Lewis at the Quality Summit last year, and she was a dynamo. She created the artificial pancreas. So we're seeing evidence of democratization of healthcare. We're seeing that people want quicker, faster solutions that meet their needs. Next slide, please. So that's why we wanted to talk about co-design. So who knows Zaina Kayat? She's from St. Elizabeth in Toronto, and I love this slide and we want to share it with you. Today's system is really about sick care. We still clearly love our institutions. In Alberta, we just got a Blue Ribbon report, which talked about the fact that we haven't moved care into the community enough. So it's been a wake-up call for all of us. We are trying to shift care into the community, but how do we do that? We're still very healthcare centric. Our healthcare services are mostly designed for the professional instead of the patient and our users. So I love this illustration because the future is really about open platforms, open source, and patients are looking for other solutions. And so it's time for healthcare to kind of move in that direction. Next slide, please. So before we get talking too much, because we don't really want to do that the whole time, we wanted to just jump right in and call it out. So if you can see this slide, when have you heard people talk about using co-design, but you knew it was bullshit? I know we have a lot of fun with these webinars and we use words that we couldn't normally use. But when were you in a meeting and people use the word co-design, co-create, participatory design, and you knew it wasn't really happening? And how did you know it wasn't happening? Like, what are some signals for you to go, is that really what this is? So what we want to do is we want to break you out in breakout rooms. I know there's only going to be 5 minutes per breakout, and you're going to be thrown together with a few other people. And in that 5 minutes, I want you to think about, how did you know, or what made you wonder if it was co-design? Or are you part of a project like AGN, and you're not sure you're doing co-design, but you're using those words? So Josh is going to throw us into a breakout now. Hold on to your socks, just press yes, and you'll get thrown back. And I'm going to ask you to report out. All right, not everyone. See you in 5 minutes. Bye.
Hello, Billy. I see your message there. We're just going into breakout spaces. I'll just send you to a room, okay? You can just hit accept. We're talking about, oh, I sent him before I told him what was going on. Sarah, I'll try and get you your audio fixed here.
Josh, can you hear me?
Yes, I can.
So one, sorry I'm late. I was having Outlook problems, but now I don't know where to from here.
That's okay. Right now, we're just doing breakout rooms, so everybody is kind of moved into a space to talk about when they seen someone using the word co-design and when they knew it was bullshit. There was something going on that just didn't kind of seem right. So
Okay.
you're stuck in this main room with me.
Well, that's okay.
So what do you think? When have you heard people use like there's so many words: collaborate, co-design, participatory design, co-creation? When's the time when you heard it and you were like, I'm not too sure?
Um, because my wheelhouse is implementation of projects, I
Yeah,
hear it all the time.
really.
And at the end of the day, it really does feel like it's 85% complete bullshit.
So what's something that sticks out to you and you're like, yeah, I can tell like this isn't like what's some of the, the flares or a warning sign?
I think some of the warning signs would be a provincial initiative that when you go to translate it down to front line, there truly was apparently no co-design because the backbone of the implementation was not designed around practice. So it'll have tremendous practice, but nobody seemed to have had the practice challenges or barriers, and nobody seemed to have the foresight to have the right people at the table as they were building it.
Oh, interesting.
Mm-hmm.
Very good. So I'm recalling everybody now. So you guys will
Okay.
be, everybody from the entire webinar should be shooting back here shortly in about 19 seconds.
Okay. I will go back on mute.
Thanks for jumping in and unmuting though. I appreciate it. They're going to come back in 5 seconds.
Hey, Josh, I'm back.
Perfect.
We were just like still using the last 15 seconds to get
That's all
something
right.
in.
That's why I did the 60-second countdown. Give everybody time to finish up.
Oh my gosh, I'm seeing all these cameras pop up. This is wicked. Huh. All right, I want to pick on someone. Who had something juicy in their breakout? I'm looking for volunteers. Who wants to speak up? Who had something juicy in their breakout?
Hi, Marlies. It's Sean.
All right, go, Sean.
A couple of things in our breakout. When we know that co-design isn't really happening, people are still working in silos, perhaps a sense of control from certain members involved in the co-design, lack of buy-in, and then something that I had mentioned was we're not starting always from a clear definition of what co-design means in that context.
Right. It is a sexy word to use. And someone in my group said, well, maybe we don't need to co-design this particular element, right? Like maybe it's when is the right scenario. One more juicy comment. Who wants to go?
For us, we had three juicy comments. The first one is when you hear people talking about what patients want.
Yeah.
That's one indicator. The second one, when you've got an advisory group and yet you go to them, but you don't see them in the actual actions. And the last one, I think, is really the most powerful one from Rhonda, that you're strategic about what we want to learn from them.
Interesting. Strategic. Next slide, please. So this is my frustration and our frustration at the lab. We often put patient advisors on committees. And is that true co-design? Is it one mechanism co-design? And when you have patients on these committees, are they users of the service you're creating, or are they in the patient advisor pool and you just need someone there to tick off the box? So there's no definite answer for that, but I've seen some instances where, for example, a group created 3 or 4 models and then went to the community and asked for feedback about the models, and they called that co-design. So what does it mean to truly co-design with your users? And so we're hoping to unpack that today. I don't want to, verbatim say whether putting a patient on a committee is co-design or not, but I really question whether or not that's really participatory, or if it's more tokenistic. And our patients who are on the call right now, definitely want you to speak up. I want you to text in the IM box, if you can find the chat box at the bottom. Do you have an example where you were part of a project or you're part of something, patient, where the system was not designed for the user? Can you throw out some examples of where you were part of something and people just completely lost sight of the user? So the user could be patients, it could be staff. They were completely missed.
Or what about even if you've interacted the healthcare system and you say to yourself, like, oh, this wasn't designed with the user. And the first example, I'm going to steal a low-hanging fruit, is when I receive a letter in the mail about my appointment with a specialist, and it came 12 months after it was requested.
Right. Go ahead. Type away. Type away. Access to continuing care. Kimberly, do you want to speak up? Kimberly, are you there?
Yeah. Was that a do I want to, or can you just?
Can you just?
So again, it was one of those sort of mandated pieces that you must create. This was the sort of future state that was requested. Was that you must create sort of this one point of access to the system. And it became about how do we best do this for our staff, and how do we ensure that we're getting referrals to the right places and managing the volume of referrals, and discussions with HealthLink, because there's, it's well known that there's this sort of one point of entry access to the system there that could have been utilized, but they didn't want to act as a call center for continuing care. And so, we do a lot of things, and not wrongly so, for the, ease of our staff, to ensure that there's that path to care that occurs. But at what point is it easy for our users to have to dig for a phone number or 1-800 number that they have to call to get access to the system?
Right. Next slide, please. Thank you, Kimberly, for responding to on the spot. So Maya isn't here, but this was her slide, and she's very adamant about co-design. She's been a patient advisor. She is a patient. She uses the system quite heavily. She's 21 years old, and continually frustrated that she can't text, she can't open encrypted emails on her mobile. It's all just super painful. But the one thing that she really talks about was, if people don't, when she is invited to be part of a group, if people are not transparent about the problem, that's her first cue that this is not going to be a co-design kind of initiative. So that's the first trigger. She also looks for, I wanted to give an example. Actually, Josh, I'll pass it to you. The example from Toyota. Go ahead.
So the example from Toyota is really about transparency about the problem, is that they were open and willing to say that they've did something wrong. And in 2010, they had a massive recall. I believe it was 70 million vehicles around airbags. And, the first thing you would assume a large corporation to do is to be like, okay, we need to manage the situation. But the first thing they actually did was they produced a video that said, we recognize we've done something wrong. And they admitted to, yes, our issue killed 70 people. that's not something you would expect of a large organization. So and of course the assumption would be their stock prices would plummet and everything would go wrong. But because they were transparent about what was happening, and then subsequently made it an effort to show them, like, we are trying to be better, people felt that there was a stronger connection to the organization. And they're still around today, and their stocks are worth more in 2019 today than they were in 2010.
Yeah. And so this transparency about the problem, like, we're very hesitant to disclose when something is not great. So that's the first cue she has. She looks for the yes and mentality, like someone who doesn't see boundaries. They look at creative solutions. And agree with Marlette. Oh, that was the last slide, Josh. Go back. You missed it. The yes and mentality. So that's another cue she looks for. And desire to change the rules. Who has heard of rules? Rules are bullshit rules. So we all know about rules, and we have to live with them as employees sometimes. But she looks for people who are willing to break the rules. And so rules that don't make sense, rules that prevent us from doing the right thing for patients. So she really looks for people who are bold and willing to break the rules. Rules came from Vishen out of Mind Valley, in case you don't know him, but and being open about rules that don't make sense. Action-oriented, she thinks, is the most important thing. If she feels like there's a lot of talk and planning, she doesn't feel like she's in a place where people want to co-design. Next slide, please. All right, so I want to ask you, so this, look at this image. How meaningful is patient engagement today? So in healthcare, how well are we doing right now? So on the left, I want you to place your dot somewhere, but I need you to type it in the chat box. So this was done at the Quality Summit last year. So is patient engagement an afterthought? Are we informative? Are patients told what has already been decided? Are we tokenistic? Are patients on a list of what to include at meetings and conferences? Are we advisory? Patients are consulted about their opinions in most situations. Is there a dialogue where patients are part of the conversations and deliberations when there's problem solving? Or are we at a place of shared decision making? Where are we at right now? And is this dial moving? So there was 80 people in the room at the time, and they voted. They said this. I think the patients had the blue dots and leaders or staff had the red dots. So what do I see in the chat box? What do we see, Josh?
Oh, I've seen some tokenistic, some informative.
Some advisory. All right. So how do we move the dial on this as we move forward, as you're working on this? Patient as leaders, informative. Okay, so we still have a ways to go. All right. Who is your department that is shared decision making? Who is that? Billy. We're an anomaly. Where are you from?
It's lunch and I'm eating pretzels.
Yes,
And my
very
mouth is
healthy,
full.
very healthy.
Thank
Yeah.
you. Yeah. They're baked.
Keener.
Yeah, I know, right? So I'm in Edmonton zone in Alberta Health Services, and I do the injury prevention program.
Oh, so you are in the public health space.
I am.
Good. Okay, it's true that is more likely that you are partnering in co-partnering and co-designing with patients.
Yeah.
Okay, I won't put you on the spot to say that it was bullshit. Next slide, please. I know. I love saying the word bullshit online. It's so liberating. Am I going to get in trouble by someone here? All right.
We're on Zoom. We could plausible deniability. The recording's now gone. No, I'm just kidding. Or at least sections of the recording are lost. So now the question that we hear a lot is, what is co-design? And there's a lot of different words for this. There's, so co-design, there's participatory design, there's co-creation, there's collaboration, there's all of these different things. And they don't actually all mean the same thing. But the idea of co-design really came out of design thinking. So when we think of co-design, it's using the design thinking process with patients and our users and family members or frontline nursing staff or medical staff, anyone who's really a part of the system. And it doesn't just begin or end with, you know, chatting with them during a certain meeting or asking them to fill out a survey. Please, God, know that a survey is not co-design, and it's nowhere near. And you'll, if you ever want to know my talk about or talk to me about surveys, let me know, and I'll really get on my soapbox. But Marlies would murder me if I continued to chat about it. But co-design, in our perspective, is around the design thinking process, and I'm going to go through that with you guys a little bit today. But I want to know from you guys, throw a yes or an N, or Y or an N in the chat box, who has seen the IAP2 spectrum of public participation? Anyone in the room? Yes, yes. Oh, a couple no's. This is the idea of that we can increase our level of public impact based off of the input that we provide for them. And I love this, not just from the idea is the impact increases when you get to empower, but just the way that this illustration is connected. So, it does connect back to the slide that Marlies was talking about. Inform is like we've made something, and you know, this is what it's going to look like. Consult's like, what's your lived experience? How are things going for you? And then we build something for you. Of course, involve is a little bit more of a back and forth, as you can see with the arrows. Collaborate is more of more connections and more people working together. And of course, there's the idea of empower. What I want you guys to know is that this doesn't just fit with co-design. You can do this with really any process, whether it's, you know, an AIW, a Lean Six Sigma, a traditional form of quality improvement. You can move yourself up the scale. And by you, I mean you're the big circle. And inform, as you can see, the circle is really, really big within the entity that's making change. That's because they hold more of the power. They're the one that's really making big decisions. Consult, it starts to get really small. But as you move yourself down the line, you know, you become, I don't want to say humble, but the powers begin to start to share throughout the entire group. And more of the decision-making power goes into your participants. And so, as you can see, it gets smaller and smaller until the very end, and in power, it's the same size as everybody else, because what you're building is more important than yourself. And at least within our world, as the designer, our level of influence gets less and less. And how does that work within design thinking? So co-design and design thinking, it's all about taking our user and bringing them from the very beginning to the very, very end. There is no break. There's no stop for when, you know, we're going to come and talk to them about what the problem may be, and then we're going to go back and define what we're going to work on. That's not how it works. Our user lives in every single step along the process. So empathy, of course, we're talking about them, but it's not surveys. It's about hearing their stories and understanding, you know, what is their lived experience, whether they're a patient or they're a nurse, it doesn't matter. They're an end user and we want to learn from them. And then we go and we say, okay, this is all what we learned. Now, where do you guys think the problem is? We take that decision-making power away from us as designers and give it to them. Where do they think the pain point is, or the area, the opportunity to improve? And then we say to them, all right, let's build some ideas together. We go through the ideation process, we hear from them, and then we take it again a step further. We then build what we came up with them. They are in the room, participating in all of that. And when we get into the last part in feedback, we get not only input from the people that were part of the design team, but we look outside, like bring in more users. This is what we've built. This is our most viable product. You know, it may be made out of Lego, but you'll be able to experience it and then get more input from them.
All right. I'm madly texting in the box. We don't hate service completely, but that's not where you should stop. It's a good starting point, but it's so easy for us to fire off a survey, but it doesn't really give you the lived experience. So we're really big on uncovering people's stories and how they live.
Hey, Josh and Marlies, can we just go back to the last slide?
Oh, yes.
I have a question about this, and I think about it a lot, actually.
Okay. Go, Sarah.
I'm also frustrated by patients sitting on committees and really not, using their experiences in the most effective ways that we can, and using their time really. And time is a precious resource, and often for patients who are in hospital and spending a lot of their time simply taking care of themselves or their family members. And we're asking for more of that time to inform our work. So I'm wondering if we can, if it would be, and I would like to hear from the patient advisors on the call, if at empathy, this is where we're collecting, you know, the patient journey, as you said, the patient story, shadowing patients for a day, and collecting that information to then maybe, and maybe at that point we can step away from the patient's life and come as a planning group and say, this is our data. How do we
what's
make
your question,
sense of
Sarah?
this?
Sarah, what's your question?
So then my question is, can we define and ideate as a professional group using the patient experience data, and then prototype as a professional quality improvement group, and then test it with the patient? That's where the patient comes back in. It's the prototype testing.
So what's your question, Sarah?
And if we got it wrong completely, like the prototype's completely wrong, then we go back to empathy. But we don't really need the patient in define and ideate and prototype.
Right. So I'm going to have Josh answer this as well. And Ali, you're on the call. I don't know if you can unmute, but essentially, and I'm going to talk a little bit about this, we usually trying to focus on a high user, the users on the margins, the marginalized groups. They will never come to a committee. They will never be a patient advisor of AHS, the people who use the service most. So right, a committee doesn't make any sense. But actually going to the field, building trust, and we actually don't think that you can even define, ideate, and prototype with a committee, because you have terms of reference, you've got all this posturing that goes on. So actually committees are probably the problem for me, right? And then we invite patients to committees. I don't know, who's a patient on the line? I just want to hear one comment. Go ahead. Who wants to speak up? Is there a patient? Josh, any comments before we move on? I'm sensitive of time.
No, let's continue on.
All right, next slide. So Sarah, this is really interesting for me, the things you're talking about. So how many people on the call currently think that we live in an old power system? Old power, currency is held and expertise is held by few. We still send out directives and hope it happens. It's a transaction. Who thinks we're still old power, please? And who thinks we're in the new power world? And that's the tension we have at play, right? We know we need to shift more to a new power, but we know the bureaucracy is largely old power. Okay, things are rolling in, largely old power. Old power, it's still happening. So my question to you is, can we actually co-design in an old power system? Is it even possible? Hey, Greg, no. I love the hippos. Glenda, do you want to speak up? I'm going to give you the line. Glenda, go ahead.
Sorry, I had to figure out how to unmute myself.
Go ahead.
I think that largely we are in an old power system, which makes it very difficult, but I think we recognize that's not where we want to be. Yeah. So I actually wrote down transition power field, because I feel like there are some areas like yours that are really taking huge strides forward and creating really good things for our organization. I just saw the Amplify app, and I'll be using it in my clinic really quickly, right?
Right. I saw your tweet. Amazing.
Yeah. So, I mean, those are that's where we're headed.
Okay.
But largely, I think we're still in the old.
Well, and maybe it's not about can we co-design or can't we? It's a dance. It's a tension we should be aware of. Phil, I cannot give you the mic for at this point in time. Do you want to speak up for a second? Is it possible to co-design in this bureaucracy? Go ahead. He's like, oh, where is my mute button?
We're not hearing you, Phil.
There you go. How's that?
Awesome. Okay, I'm giving you the mic, but make it brief.
Well, I think the problem exists before we even get to the co-design stage, in that quite often the definition of the problem that we're trying to solve is defined by providers, and it's not actually a patient problem or an experience problem. So we don't do any deep dives into, well, what's really wrong?
Right, right. The problem framing. Yeah.
And that's,
yeah.
and that's,
right.
That's the biggest challenge I think we
Mm-hmm.
have, is that
right.
Providers define a problem the way they see it and what they think it is. And then they say, okay, we got to get patient advisors in to figure out how to help us.
Right, but they're focusing on not the right problem, but they've already made that decision.
They're focusing on the problem from their lens.
Right, they think it's the right one. Right, right.
Yeah,
Yes.
the idea is that
more often than not, I've been involved in what people like to call co-design.
Right.
And we're really there to rubber stamp what's already been done. And so when the committee or whoever goes back to ELT or whoever they have to go back to, we solved the problem and we did it with patience. Hallelujah. Let's go.
Right. Okay, I thank you. I'm now moving on, but the chat box is on fire.
So the quote you were wondering about, Marlies, from the Mars Solutions Lab, it is that you live and you die by your problem frame. If you get the wrong problem selected, it doesn't matter how great you are or how good you are at your job. If you're working on the wrong thing, you're gonna never meet the needs of your user.
Okay, next please. I want to call out Lauren. Everyone's texting me. Lauren. Can you unmute your line? Tell me what you're thinking. Next slide is fine. Lauren, hello. Okay, just yell at me when you get online. So we went bold and we said, oh my God, let's make a list of what we think we need to think about when you're truly co-designing. And Phil, we have to add the problem framing here because you're right. Often we're looking at Laurel. Yes, Laurel. Okay, Ali, you said Lauren. Laurel, yes, it's you. Go ahead. Can you unmute? It's still a one-way street. So I want to go through this list of a checklist. So next time you want to co-design or you think you want to head in that direction, these are the things we want you to talk about. No, Laurel, I cannot hear you. So the first thing is inclusivity. Are the users part of the problem framing, even from the very get-go, Phil is talking about, all the way through the process? And that includes ideating, it includes prototyping, building, everything. So it's all along the way. Equality, are the users considered experts? So are they purely bought in, or are they considered equals, and are they guiding the process? Participation, a strong decision process offers opportunity for involvement in a wide spectrum of users and stakeholders. So again, Josh, anything to add here under participation?
It's just really that the power goes in both sides. The voting power, doesn't matter what your background is or your title, your dot is worth the same as anyone else's dot.
Okay, or more. Go ahead and finish the list for me.
So yeah, and it all jumps into like shifting ownership, right? So when we talk about that, is that, you know, as the designer on the IP or IAP2 scale that you've seen, the power moves away from you and into the user. So you really have to see that if it's going to be true co-design. And of course, that last piece is iterative, making sure that your users that are part of your design team are they're not the only ones to test it, right? Send it out to people that are outside of your design team. Let them experience it.
And I think with the shifting ownership, like if someone is really dead set on having their logo profiling who should take credit for the work, you are definitely not shifting ownership. So drop those logos and your AHS templates with the community, because it just looks like you're posturing. Next slide, please.
Laurel is, I believe, ready to talk. She should be unmuted. So,
Laurel,
are you ready to rock?
all
Okay.
right, go ahead, Josh.
If Laurel, if you get it going, just yell at me. I'll stop. So who is using co-design? We get asked this a lot. And I don't know if anyone has heard about the Design Institute of Health from the University of Texas at Austin, the Dell Medical School. They're using real co-design. So they built this absolutely fantastic clinic where they thought, how can we build a clinic that is truly centered around the patient? And the very first meeting they had with the architects, there was a question, where are we going to put the waiting room? And everyone on the design team, including the users, was like, well, do we really need a waiting room? And everyone just paused. They're like, well, everybody has a waiting room. Shouldn't you have one? And they changed the idea of what a clinic could be. It's ran more like a hotel and an airport than an actual clinic. There's a front of the house, whereas the users, go to a desk, they get a ticket that tells them which room they're going to go to. The wayfinding is a lot like an airport. And then everything else behind the scenes, like physicians, lab techs, it's not done in the same space. And you walk into the room.
Okay.
And
all right. The next one is by the Open Lab out of Toronto. So you see on the left, there's a Bluebird app. And what they looked at the opioid crisis, and they knew they were trying to build more supervised consumption sites. They had naloxone kits available everywhere. They had a Good Samaritan overdose line encouraging people to call 911, and you wouldn't get tangled up in some legal battle, even though you were using as well. But they started realizing that 50% of all the deaths are when people are using alone. They're not with anyone. No naloxone kit is going to save you if you're alone. So the Open Lab actually started spending time with users. There was huge mistrust initially, because it's like, okay, there's this behemoth hospital and they now want to save the day in the opioid crisis. Yeah, right. So they talked about actually spending nights and evenings trying to build relationships with users. And the users finally said, all right, we trust you, and we actually want to create an app so that in a high rise, I have people in my building that I can actually contact if I'm using alone and I need help. So this app took 2 years of the making, and in part because they had to build trust with these extreme users. And I've mentioned this once, but extreme users, people who are using the service the most, it's very easy to go to people who are the average user. You might even get them on a committee because, they're organized to be able to sit there. But are those the people that you're really trying to access? Next slide, please. Go ahead.
So an example that we done at the lab. So already talked a little bit about this today, the food services redesign with Care West in Calgary. And they had attempted for 30 plus years to change the way they deliver food services, and they never were able to get traction. So the first thing that we wanted to do was follow the food, of course. The next thing was we held a discovery day with 60 people, both residents, leadership, and frontline staff, and actually feed them the food. Let them all experience what the patients or the residents, experience every single day. And the whole mindset, the feeling in the space changed as soon as senior leaders were experiencing.
Was it bad?
Well, it was not good. We started to probe them in questions like, so how's the food? And they're like, well, it was okay. And I said to them, if it was a restaurant, would you go back or would you bring your family here? And it was a resounding no.
This is gross.
So they all realized that they needed to change, and now they've got the traction because everybody is bought in, because they all experience what residents have to experience every dinner time. And now this is actually a photo of their food. This is not stock imagery that I've stolen from the internet. They, in 2 sites, they're continuing to roll out their prototype on actually producing fresh food for their dinner times.
All right. I want to do a quick check-in. I've got Q2. How is everyone doing? Are you ready to keep going for a few more minutes? We wanted to share with you, okay, so now that we know we could do a whole lot better with co-design, co-participation, problem framing, Phil, you're so right. What are some ways that we can actually start on this path? Because it's a journey, right? So empathy maps. If you don't know what that is, you should know what that is. Google it. We have a link at the end of the slide pack. We're going to share it with you. We use empathy maps at the beginning of sessions very often. I did a session in Lethbridge where we were looking at moms who were coming in to deliver babies, but they were addicted to drugs. And as soon as we did the empathy map about how is this mother feeling about coming to a hospital to deliver a baby while she's thinking of her next fix and while she's dealing with all these things, it completely changed the atmosphere in the room. Everyone was like, oh my God, this must be terrible. We send in a male addiction counselor the minute she's delivered the baby. Like, how inappropriate can we get? Like, it was just like, oh my God, are we really doing that? That's terrible. So this is a tool you want to try out. Next slide, please. Yours.
So then someone in the chat box I seen mentioned being an ethnographer, doing ethnographic research. With design thinking for us, it's all about hearing stories and just talking to people. And I had the opportunity to work up in Northern Alberta and talk about elderly loneliness and how might we, change the system or incentivize the system so that seniors are reaching out more and they're connecting more to decrease the chance of them experiencing this. And there's a lot of awesome data and metrics around this. Like 1 in 4 seniors experience loneliness. You're 4 to 5 more times likely to be hospitalized if you're lonely. But I met Melvin, and he talked about how he wished there was only 18 hours in a day. The evening hours was the worst, where he contemplated ending everything. Those stories are super impactful, and when you share them with your teams, they start to be more bought in. They get more interested. They want to start to change the system because they know that Melvin is not alone in this experience. There are thousands of Melvins out there, and then there's like this newfound energy for what they're working on.
All right.
The next thing we like to do is journey mapping. And I know another map. No, it's not like a process map. It's not a swim lane. This is all about the patient's journey as they move through the system, whatever it may be. We met this fantastic designer named by Andrew Sue. His Twitter handle is down in the corner there. I encourage you to follow him. And they built this journey map to kind of show what the experience may like just to go through a taxi cab. But really what it's around is seeing what the patient goes through step by step and how it affects their emotions. Does it make them more stressful? What are pain points and things that don't work? What are they thinking or saying that really kind of change their thoughts and how the system works for them? This is a great tool to kind of see how everything is working within your group or the project that you're working on right now in its current state.
All right, before we finish up this call, I just wanted to pick on my colleague Erin, who's with the Design Lab. Erin, your wheelhouse is problem framing. Do you want to give us a quick idea about how we could do a better job? And Phil, can you tell us if we're on the right track when we say this? Go ahead, Erin.
I think that, well, certainly just some of the work that I've done recently is that if you don't speak one-on-one with people that are experiencing the problem, and if you do, and this ties back to why surveys or focus groups can be kind of a red herring, is because if you go into situations with people one-on-one, they'll tell you about their personal stories and about things that maybe they think only affect them. If you go into a survey or a focus group situation, you're almost looking to validate what you already think you know about the problem, and you don't have the opportunity to follow those cow trails or to get those personal stories that might inform you of a different reality than what you think it is. So it does help you shift and kind of focus in on what the end user really thinks that the problem is in that way.
Yeah.
And then also, if you can't step outside of the problem and consider that you might be working on the wrong problem, then it's almost as detrimental as thinking about a solution too quickly in the process. And thinking that if you think you have the right problem and you're not willing to examine that, you could be taking yourself down a long path of wasted time and effort.
Right. Thank you, Erin. All right, we're opening up the lines. We have a few more minutes. We never want to go for the full hour. Are there any questions or comments? Speak up now before we sign off. 91 participants. I'm so impressed. While some people are thinking of questions, could you type in the chat box? Was this call remotely helpful? Was it bullshit? Was there some meaningful conversation? Who's this? Go ahead.
It's Geraldine, and I just wanted to clarify, in terms of empathy mapping, what is the outcome that you're hoping to achieve? Like, what new information do you get from that process?
All right, Josh, yours, go.
Sorry,
what are you trying to get out? What are you trying? Okay, so I'll answer it.
Immersion understanding is what you get from empathy mapping. You
Thank
get an
you.
opportunity to be immersed in what the experience is like.
Can you show me the slide, Josh? So essentially, what you're trying to get the group to start thinking from the perspective of the person you're doing the empathy map around. So in my case, or say with the Open Lab case, it's about drug users who use alone, and you start thinking about what are they thinking and feeling. So you're really working through their lens, like you're trying to immerse yourself, and it gives you an opportunity to find pains and gains, which are what are the pain points and what are the opportunities. Geraldine, does that help? Like it kind of just puts you in the place of the user.
Right. Okay, thank you.
No worries. Any more questions?
Yeah, we had a question from Nicole that asked us, do frontline staff and providers ever need to be considered a user? So it really depends on the project and where you're working. And sometimes you have two end users, and maybe the problem statement may be different for each group. But like, Ariel from our solutions lab said, if you're not working on the right problem, or you live and you die by your problem frame, and you may have two different contexts to think of. So yes.
I know people are working on the opioid crisis and naloxone kits. So yes, users can be part of our professionals can be part of your user group. Who's next? Is that Joanne Ganton? Who wants to speak up? I heard a voice.
We're asking them to get into all the stages. Sometimes we're asking them to be involved a lot, and our patient advisors are involved in many activities, and we're sensing a real struggle and a challenge with balancing that ask of their time. They can't work, an hour or two every week alongside of us if we're truly co-designing with them as equals.
Right.
If I can just say one thing, this has been wonderful to be part of this. I'm from the PACER program at the University of Calgary, and we do a can I say shitload of co-design?
Yes, I love it. I've got other people saying shit on the call.
One of the things I'm really discovering is citizen science. It's been something I've been involved with for years on the periphery, but boy, the whole notion of citizens actually making change. So it's not just at the co-design stage. It's really them being involved in collecting their data in new ways. And some of the ways, things like patients like me or all of the things that are happening. I think we sometimes need motivation to get out of our box. We're in our sort of AHS box. And sometimes we need to look at the world.
Yeah, love it very much, especially with our complex challenges. We have to go outside. Yeah. So Emily Ellis has a modified empathy map she wants to share. I'm going to email it out along with the slide pack, or just, how to find us, design.lab@ahs.ca. I'm going to conclude the call. Please let us know how you like this this webinar. We can do more. Please don't report me for using the word bullshit too much. And have a wonderful rest of the week. And hopefully we can co-design in a more meaningful way. Thank you everyone for joining us. We will send you the recording in case you're interested. Bye.
Bye everybody.
Bye-bye.